Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY4 resident at the University of Pittsburgh in radiation oncology, and this is part 2 of breast cancer overview. In part 1, we talked about the presentation and workup of breast cancer. We reviewed screening guidelines, and then we got into some nitty-gritty details of breast cancer imaging, as well as pathology, including what kind of morphology we're looking for, molecular features of breast cancer, and specific factors that we would look for in a pathology report. In part 2, we will wrap up our overview discussion by first reviewing the staging of breast cancer and then getting into the treatment paradigm. Let's start by talking about the staging of breast cancer, which is something we kind of have to memorize for board exams. So the AJCC, or the American Joint Committee on Cancer, fortunately has not yet changed the staging for breast cancer. And so this TNM staging is from the AJCC 8th edition, which you can always look up the most up-to-date version of staging on nccn.org, where the treatment guidelines are for every single cancer type. And so this staging is for the AJCC 8th edition. So the T stage for breast cancer is dependent on the size of the lesion. We already talked about in part 1 how TIS is considered ductal carcinoma in situ. That's cancer that's within the duct and has not broken through the basement membrane of the duct. T1, T2, and T3 are all dependent on this size. So T1 is anything less than 2 centimeters. T2 is 2 to 5 centimeters, and T3 is anything above 5 centimeters. But within those, they get broken down a little bit. So there's our subcategories for T1 breast cancer. T1MI is anything less than or equal to 1 millimeter. So it's T1 microscopic. T1A is anything greater than a millimeter, but less than or equal to 5 millimeters. T1B is greater than 5 millimeters, but less than or equal to 10 millimeters. And T1C is anything between 10 to 20 millimeters, or 1 to 2 centimeters. So just remember that T1 is less than 2 centimeters. T1A and T1B are less than 1 centimeter, but divided by that 50% mark, so 5 millimeters or less is T1A, greater than 5 millimeters is T1B, and then T1C is anything between 1 to 2 centimeters. So that is the T stage for T1. T2 is anything greater than 2 centimeters or less than or equal to 5 centimeters, and T3 is anything greater than 5 centimeters. So remember that for T stage for breast cancer, it's based on the size until you get to T4. And in general, for all cancers, T4 is something that's really invasive and starting to invade into other structures or organs. So T4A indicates that the cancer is invading into the chest wall, not the pectoral muscles, but the actual chest wall itself, so like the rib cage. T4B is when it's invading into the skin, either via ulceration, satellite nodules, or edema of the skin. So T4A, it's invading internally into the chest wall. T4B, it's invading externally towards the skin. T4C is when you have both T4A and T4B, so both chest wall and skin invasion. Think of it as T4C as T4 combined, T4A and B. And then finally, T4D is the worst. So think T4D dam. It's inflammatory carcinoma. So T4D is inflammatory carcinoma. Okay, so just to recap the T stage, TIS is ductal carcinoma in situ. T1 is anything less than 2 centimeters. T2 is 2 to 5 centimeters, and T3 is greater than 5 centimeters. T4A invades the chest wall. T4B, it invades the skin. T4C, it invades both. And T4D is inflammatory carcinoma. That is the T stage. Now moving on to the N stage. So there are 2 different end stages depending on if it is clinical end stage or pathologic end stage. So let's start by talking about clinical end stage. When we denote that this is clinical end stage, we say CN0. So a little c followed by a capital N and then whatever number. So CN0 means that there are no clinical lymph nodes involved. And the way that we assess clinical lymph nodes is based on exam and sometimes like axillary ultrasound or maybe MRI. So if there's no suspicious lymph nodes on our clinical exam based on exam and imaging, we say CN0. CN1 is if we have movable ipsilateral level 1 to 2 axillary lymph nodes. So movable ipsilateral level 1 to 2 axillary lymph nodes. And C1MI is anything that's less than or equal to 2 millimeters. So greater than 0.2 millimeters or less than or equal to 2 millimeters. But in general, just remember C1 is movable ipsilateral level 1 to 2 axillary lymph nodes because that's the first place that lymph nodes are most likely to appear if the cancer spreads to the nodes, is the low axilla, which is level 1 and 2. CN2 then is divided into A and B based on the following. So CN2A is fixed or matted ipsilateral level 1 to 2 axillary lymph nodes. You can imagine that if the nodes are fixed, matted, they're not movable. That's a little bit worse than if they were movable. So that's N2A. And then N2B is if we have ipsilateral internal mammary nodes. So think of N2B as the breastbone. And so the sternum is your breastbone. So the ipsilateral internal mammary nodes are the ones that are close to your breastbone, N2B, maybe to help remember that N2B means ipsilateral internal mammary nodes. Keep in mind that if you're CN2B, that means you only have internal mammary nodes and no axillary lymph nodes. CN3 is more advanced than even those two now, right? So CN3A is if you have ipsilateral infraclavicular lymph nodes. So N3A is now axillary level 3. And you can remember that it's in the name, right? A is axillary, N3 is axillary level 3. So CN3A is ipsilateral infraclavicular lymph nodes. CN3B is if you have both ipsilateral internal mammary and axillary lymph nodes. So remember N3B, here the B stands for both. So you have both internal mammary and axillary lymph nodes. And then finally, CN3C is ipsilateral supraclavicular lymph nodes. If you recall in part 1, I talked about how supraclavicular is considered regional nodal for breast, but by the time it's spread to the supraclavicular nodes, it's not considered metastatic, but it's almost metastatic. It's very advanced, so CN3C, okay? So just to review the clinical end stages again, N1, movable ipsilateral level 1 to 2 nodes. N2A is if those axillary level 1 to 2 nodes are fixed or matted. N2B is if you have just internal mammary nodes, so just ipsilateral nodes near the breastbone. CN3A is if you have ipsilateral infraclavicular nodes, so axillary level 3. CN3B is if you have both ipsilateral internal mammary and axillary nodes, and CN3C is if you have ipsilateral supraclavicular nodes. So these are the clinical stages. Now, once a patient undergoes surgery and they get either a sentinel lymph node biopsy or they get axillary lymph node dissection, then the end staging is dependent on their pathologic stage. So now we have a PN stage, and the pathologic node staging is a little bit different than the clinical node staging. For the tumor staging, on the other hand, the CT or PT, you still use that nomenclature, but the staging itself doesn't change, but you still have to indicate what the clinical staging was and then what the pathologic staging was. But for the nodal staging, the pathologic is a little bit different now. So what is that? So for pathologic staging, we have N0, which is no lymph nodes, and then there's something called ITCs, or isolated tumor cells. These are if you have spots of cancer that are less than or equal to 2 millimeters. So just tiny spots of cancer, less than or equal to, 0.2 millimeters. So really, really microscopic. These are just isolated tumor cells, and you would denote that as PN0I+. Doesn't really change our management in breast cancer. Then we get into PN1, PN2, PN3. So PN1 is based on, so now these PN nodes are kind of based on the number of nodes. So in general, I think of PN1 as 1 to 3, PN2 as 4 to 9, and PN3 as greater than or equal to 10. And this is for the axilla, okay? This is PN1A, PN2A, and PN3A. Is we're counting the nodes in the axilla because the reason we only count the nodes in the axilla is because when you're thinking about the surgeon doing the dissection, it's really only the axillary nodes that they can get to. They don't go and dissect underneath the pec muscles. They don't dissect the infraclavicular, supraclavicular, internal mammary spaces. So they're really just able to dissect kind of the low axilla. And so that's what we can count. And so that's what our staging reflects. So remember that the A annotation for PN1, N2, and N3, we're counting the nodes in the axilla. So PN1A is 1 to 3 nodes. PN2A is 4 to 9 nodes, and PN3A is greater than or equal to 10 axillary lymph nodes. These nodes have to be at least 2 millimeters in size. If they're less than or equal to 2 millimeters, then it's PN1MI. Now, we get into the other subcategories of the P staging. So PN1B is if you have ipsilateral internal mammary sentinel nodes. These are not isolated tumor cells, but just internal mammary sentinel nodes. Remember, if we had ipsilateral internal mammary nodes in the clinical staging, that made us CN2B. But now, if you have ipsilateral internal mammary sentinel nodes, that makes you PN1B. And then PN1C is if you have both 1 to 3 axillary nodes that are at least 2 millimeters in size, plus the ipsilateral internal mammary nodes. So PN1C is N1A and N1B combined. Moving on to PN2. Remember, PN2A was 4 to 9 axillary nodes. PN2B is if you have clinically positive IMNs and a pathologically negative axilla. So PN2B is kind of the same as CN2B because we just had the ipsilateral internal mammary nodes and no axillary nodes. But just remember that PN1B is if you had ipsilateral internal mammary sentinel nodes. And then finally, we have PN3. So remember, PN3A was greater than or equal to 10 axillary nodes. PN3B is if you have a pathologic axillary node and positive IMNs. So PN3B and CN3B are kind of the same. PN3C is if you have ipsilateral supraclavicular nodes. So CN3C and PN3C are again the same. So I think largely the clinical and pathologic stages for the lymph nodes are very similar. The biggest difference is that in the axilla, when we get to the pathologic end stage, we're now counting. So PN1A is 1 to 3, PN2A is 4 to 9, and PN3A is greater than or equal to 10. That is a lot of information, but it's just something you kind of have to memorize and get used to memorizing. In reality, you'll probably look it up when you're in attending, but for the purposes of boards, we kind of have to memorize these. Now, finally, that brings us to the M stage. So M stage is easy. CM1 is a clinically detected macroscopic metastasis, and PM1 is if we have a pathologically detected macroscopic metastasis. There is M0I+ if you have, think of it like isolated tumor cells somewhere else besides the breast or regional lymph nodes, so like a less than 0.2 millimeter metastatic deposit. But really, it's M1 is if you have a metastasis anywhere outside of those regional lymph nodes, and CM1 is clinically detected, PM1 is pathologically detected. The way that I was taught to write my note when we're evaluating these breast cancer patients and writing their H&P note, I was always taught to write the full clinical stage, so CT, CN, CM, followed by the pathologic stage if they had already had surgery at the time of consult, so PT, PN, PM. And I always wondered kind of why we do that, but I understand my attending explanation and it makes a lot of sense. So first of all, that's important if they received any kind of neoadjuvant therapy. So let's say they received neoadjuvant chemotherapy and they had some down staging. So the way that we denote that is by saying a little Y and then a P and then the T and N and M staging. So that's an important way of kind of noting what the cancer was like clinically. And then if we say YP, we know they received some upfront systemic therapy. And then by the time they went from surgery, maybe they went from a T2 to a T1C or something like that, or maybe from an N1 to an N0. Even if they did not receive any upfront systemic therapy, however, it is important to note the difference between the CT, CN staging and the PT and the PN staging, because things may look different clinically and may actually appear different when they go for surgery. So I was always taught to write both the C staging and the P staging for patients that have already had surgery. For breast cancer, TNM staging is probably going to give you the most information when you're looking at a note, but it's important to be aware of the group staging because whenever we think about the group staging, it kind of affects our treatment paradigm. And this is also something you might get asked about on board. So it's important to understand how the TNM translates to the group staging. So the easiest one to know is M1, right? As soon as it's M1, we know that it's stage 4. And for breast cancer, you have to have a metastasis outside of the regional lymphatics in order to be considered M1. And that's the only way that you can be considered stage 4 as well. So for breast cancer, stage 4 is easy. It means that the cancer has spread somewhere else besides the regional lymph nodes. The next stage is stage 3, and stage 3 is divided into different categories, but more so than knowing 3A versus 3B versus 3C, I think what's really important to understand is what constitutes a stage 3. So having T3N1, so if we're thinking about the after surgery, having pathologic N1, that means that your tumor is over 5 centimeters, right, T3, and you have N1, so any number of axillary lymph nodes positive. So if the tumor is greater than 5 centimeters and you have any number of axillary lymph nodes positive, that automatically makes you a stage 3. The other thing that automatically makes you a stage 3 is if you have a T4 tumor. So you don't have to have any lymph nodes positive, but if you have any tumor that's invading into either the chest wall or the skin, or if you have inflammatory breast cancer, that automatically makes you a stage 3. And then finally, what if you have a smaller tumor? How many nodes do you need in order to be considered a stage 3? So if your tumor is T1 or T2, right, so smaller than 5 centimeters in size, you need to have at least 4 lymph nodes in order to be considered pathologic N2 and to be considered a stage 3A. Or you need to have those internal mammary lymph nodes, right? So for smaller tumors that are less than or equal to 5 centimeters, in order to be considered stage 3, if you're thinking about pathologic node staging, you need at least 4 axillary lymph nodes, or you need to have internal mammary lymph nodes that are not just sentinel lymph nodes. So that is how you become stage 3 if you are T1 or T2, is by having a certain number of lymph nodes. On the other hand, if you're T3, so the tumor is greater than 5 centimeters, then any number of lymph nodes will make you a stage 3. I think understanding the distinction between what is a stage 2 and stage 3 for breast cancer is probably the most important thing. And then the other things kind of fall into place. So T3N0 is considered stage 2, T2N1 is considered stage 2, T2N0 is considered stage 2, and then T1N0 or T1N1MI is considered stage 1. So most important takeaways from the group staging, I think, stage 4, you're metastatic. Stage 3, you're either T2N2, T1 to 2 N2, you're T3 N1, or you're T4 N0. So you can kind of see that stepwise effect there. So the smaller the tumor is, the more lymph nodes you have to have in order to be considered stage 3. So I hope that makes sense. And I know we spent a lot of time on staging, but staging is important to memorize. So I'm hoping that kind of by slowly going through it, we can kind of really reinforce what the TNM and the group staging is like for breast cancer. Okay, so breast cancer staging was a lot. It's a lot to unpack and memorize. Let's move on now and talk a little bit about an overview of how we treat breast cancer. Breast cancer is a surgical disease. Okay, the primary treatment for breast cancer is surgery. And any other treatments that we might offer, radiation or endocrine therapy or chemotherapy or any targeted or immunotherapy agents, these are all to reduce the risk of recurrence. But a lot of breast cancers can be cured with surgery alone. And so surgery really is the standard of care unless the patient is metastatic. All of these patients should be getting some type of surgery. Now, surgery may be done up front or it may be performed after neoadjuvant systemic therapy, depending on the clinical scenario. It used to be that we would treat all patients with radical mastectomy. So radical mastectomy is very invasive and it involves en bloc removal of the breast, the skin, the pec major and minor, and axillary levels 1 and 3. We have moved away from doing such invasive procedures now. That was kind of an old standard of care. And in the modern era, we're not as aggressive with the surgery because, as you can imagine, it has drastic consequences for the patient's, psychological as well as functional endpoints. And so we've moved away from doing such an invasive surgery. Nowadays, if we're doing a mastectomy, it's usually either a modified radical mastectomy, which involves removing the entire breast, pec fascia, and just axillary levels 1 and 2, so typically not level 3. Or we might even do a less invasive mastectomy, either a total mastectomy where we just remove the breast tissue, and then there are skin sparing and nipple sparing options as well. We'll talk about the data for breast cancer later, but there was an old study that kind of showed that one way of sparing patients an entire mastectomy was to actually do a lumpectomy, or what's also known as a segmental mastectomy, where you just resect the tumor. A lumpectomy plus radiation in one of these studies that we'll talk about down the road kind of showed equal outcomes to a mastectomy. And so when possible, a lot of patients will opt for this breast conserving approach with what's known as segmental mastectomy or lumpectomy followed by radiation, with the understanding that that provides equivalent outcomes compared to a modified radical mastectomy. And so nowadays, we're more and more patients, and this is probably the most common type of surgery you'll see, is this lumpectomy or segmental mastectomy with a breast conserving approach. Now, keep in mind that sometimes when patients present with upfront breast cancer and the surgeon talks to them, they say, if I were to operate on you today, I would need to do a mastectomy. And so in some cases, we might consider offering neoadjuvant chemotherapy to try and achieve some downstaging and kind of decrease the intensity of the surgery that the surgeon would need to perform. So surgery is the mainstay of treatment for breast cancer. All patients should get surgery at some point. Anything else that we do is to kind of reduce the risk of the breast cancer ever coming back. That includes radiation and any of these systemic therapies we might offer. Although in some cases, systemic therapy is preferred up front if the patient is hoping for a breast conserving approach and we're trying to convert something that's currently not amenable to lumpectomy into something that could be amenable to lumpectomy. So that's the big takeaway here. If you recall from part 1 of the breast cancer overview lecture, we discussed what is considered a clear margin. So technically, anything that has no tumor on ink is considered a negative margin. And for invasive breast cancers, having no tumor on ink is also satisfactory for a clear margin. For DCIS, however, remember we said that you need to have at least 2 millimeters to be considered a clear margin. So just having a negative margin for DCIS is not enough. You need to have at least 2 millimeters of a clear margin, or if not, it's considered a close margin or high risk of recurrence. And the point that I want to make here is that when we offer radiation adjuvantly, so let's say it's the setting of a segmental mastectomy, and we're offering adjuvant radiation with the understanding that lumpectomy plus radiation is equivalent to mastectomy, radiation will not make up for a positive margin. So if it's an invasive ductal cancer and tumor is going up right up against the edge, and we do see tumor on ink in that last kind of inked margin, if that margin is positive, the radiation will not make up for it. So the standard is to ask the surgeon to take the patient back to the operating room for re-excision of the positive margin. And what you'll learn is that if that margin keeps coming back positive, then that's actually a contraindication to a segmental mastectomy, and that patient might need to convert to a mastectomy. So if you go by the book, having any kind of positive margin, you need to ask the surgeon to take that patient back to the OR for a re-excision. And if that margin keeps coming back positive, if they're not able to get a clear margin in that area, then that patient probably should not be getting a segmental mastectomy, and they should probably just go for a total mastectomy to clear the margin. Besides taking care of the primary tumor, the other thing that we have to address is lymph nodes, right? And remember that there are 3 major areas that are considered the regional lymphatics for breast cancer. So these include the axillary lymph nodes, supraclavicular, and internal mammary lymph nodes. The internal mammary and the supraclavicular lymph nodes, unless there's like a sentinel biopsy to the internal mammary nodes for whatever reason, these nodes are typically not addressed surgically. It's only the axilla that the surgeons really can access. And historically, what all patients used to get was an axillary lymph node dissection, which involves dissecting the entirety of level 1 and 2 axilla. The old radical mastectomy used to go after level 3 as well, but we've moved away from that. And if patients get an axillary lymph node dissection today, it's typically just axillary levels 1 and 2 that we're going after. The big downside of axillary lymph node dissection, however, is that there's a high risk of lymphedema, around a 25% risk. So patients can get arm swelling, and it really affects their quality of life. Nowadays, the only patients that are getting axillary lymph node dissection are patients that either have inflammatory breast cancer or a clinically positive axilla if they did not receive neoadjuvant chemotherapy. So axillary lymph node dissection kind of was the historical standard, but because of that really high risk of lymphedema and the consequences on the patient, we're moving away to getting a sentinel lymph node biopsy in most cases. So what's a sentinel lymph node biopsy? If you ever had a chance in medical school or whenever to kind of go into the OR and watch surgeons do breast surgery, it's actually really cool. So there's 2 different dyes that they can use, and the best way is to actually use both tracers. So the first one is a radioactive tracer, which is a technetium 99 sulfur colloid. And you can also inject the tumor with not just the radioactive tracer, but also the isosulfan blue dye. And then the surgeon will use this gamma probe to locate that radioactive colloid that they used to trace the sentinel lymph nodes. And then they can also visually see those nodes based on whether or not they take up the dye. So using these 2 different approaches, both the radioactive tracer and the blue dye, the surgeon can locate the sentinel lymph nodes in the axilla and then only remove the nodes that have taken up the tracer and the dye. On average, this results in maybe 2 to 3 lymph nodes being removed, but it can vary. And, we'll talk in the future about different studies comparing the sentinel lymph node to axillary lymph node approach or dissection. Keep in mind that these sentinel lymph node biopsies can have a false negative rate of 8 to 10%. But the positive of this is that it results in much less lymphedema and pain and improved arm mobility. So nowadays, most patients with invasive breast cancer will undergo a sentinel lymph node biopsy to assess that lymph node area. The only patients that we really consider for omission of the sentinel lymph node biopsy is T1 hormone positive patients that are very elderly. These are kind of the only patients that we might consider foregoing that sentinel lymph node biopsy, but the vast majority of patients that you'll see will actually get this sentinel lymph node biopsy. What about patients with DCIS? So the risk when you're undergoing surgery for DCIS is that maybe when that pathology comes back, you'll find out that in fact it was an invasive cancer. There was an invasive component there, and then you have to treat it like an invasive cancer, right? So if patients undergo a lumpectomy for DCIS, it's not as much of an issue. But if they undergo a mastectomy, then let's say down the road, the pathology takes a few days after surgery to come back. So if they underwent a mastectomy and then you found out that in fact they did have invasive cancer, it's really hard to go back and assess the sentinel lymph nodes because at that point you've already removed the cancer. So in this case, if patients with DCIS are undergoing a mastectomy, you should get a sentinel lymph node biopsy because just in case there's invasive cancer, you won't be able to go back and do the sentinel lymph node biopsy at that point. So if you're doing a mastectomy for a patient with DCIS, get the sentinel lymph node biopsy because if you don't and they turn out to have invasive cancer, then you're kind of signing them up for an axillary lymph node dissection, which remember has a very high morbidity. So as we discussed, surgery is a must, right? And everything else that we do beyond surgery, including radiation and any kind of systemic therapy, is just to reduce the risk of the cancer coming back. And remember that if a patient has a positive margin, radiation is not going to make up for the positive margin. Sometimes if they have a mastectomy and they still have a positive margin, it's really hard. There's nothing for the surgeon to kind of go after. And so in that case, you kind of have to make do and kind of maybe give an extra boost of radiation to the area of positive margin in the case of a mastectomy. But after a lumpectomy, we really need that positive margin to be completely eradicated by the surgeon before we proceed with the radiation. So then radiation, okay? Radiation is always given adjuvantly, so after surgery is done. And the need for adjuvant radiation really depends on what kind of surgery they had and what the stage of the cancer was. So following lumpectomy, adjuvant radiation is the standard of care. And in future talks, we will go over more of the evidence base for this. But a long time ago, there was a study that compared mastectomy to lumpectomy plus radiation. And they realized that if you do lumpectomy alone, the risk of the cancer coming back is higher. But if you do lumpectomy plus radiation, then it's the same as if they got a mastectomy. So that is why for most patients after a lumpectomy, they always get adjuvant radiation. Some patients who are older and have favorable risk factors, so hormone positive, small tumors like T1 tumors that are N0, these patients may be considered candidates for endocrine therapy alone. And again, in the future, we will talk about the data for this, but there are studies that show that in these patients, so over 65, T1N0 with hormone positive, HER2 negative tumors, the local recurrence is around 5 to 10% without radiation versus 1 to 2% with radiation. And so radiation still offers a local control benefit in these patients. So it's often a risk versus benefit discussion. These patients still have to take endocrine therapy for 5 years. And there are ongoing trials to see if maybe doing just the radiation and omitting the endocrine therapy might be equivalent to doing 5 years of endocrine therapy with no radiation. So these are ongoing kind of areas of investigation. Some patients, if they truly are older, have favorable risk factors, and maybe if breast cancer is not going to be the thing that affects their mortality, they may be considered candidates for omission. But for the most part, we offer radiation after lumpectomy because it decreases the chance of the breast cancer coming back. So it offers a local control benefit. After patients undergo mastectomy, now remember mastectomy, we're taking out the entire breast. So a lot of times these patients don't need adjuvant radiation following a mastectomy, but they will need it if there are certain indications. So absolute indications for post-mastectomy radiation, if a patient has T3 to T4 disease, so greater than 5 centimeters and invading into things like the skin or the chest wall, if they have 4 or more positive lymph nodes, because remember, having 4 or more positive lymph nodes, no matter what size tumor you have, that makes you stage 3. And then also if they have positive surgical margins. Remember, we always want to go after those margins, but after a mastectomy, sometimes there's really no tissue left for the surgeon to operate on. And so then in that case, we do have to kind of settle for radiation to the chest wall, plus maybe a boost to that area of positive margin. If patients have 1 to 3 positive lymph nodes, we strongly consider post-mastectomy radiation per NCCN guidelines. And T3N0 disease is kind of another area of controversy. So for T3N0 disease, we might take into consideration other risk factors, such as whether or not there was LVSI, if it was high grade, if they had close or positive margins, or if they're premenopausal. So breast cancer, there's a lot of research still going on. There are a lot of studies that have been done, and there are certain areas of controversy. But following a mastectomy, we only give adjuvant radiation if patients are truly really high risk. So T3 to T4, 4 or more positive nodes, and we consider it if they have any positive nodes or if they have positive surgical margins. And then finally, the other area that we can irradiate besides either the breast or chest wall is the regional lymph nodes, right? So regional lymph node irradiation is typically reserved for patients that have node positive disease. And what we end up treating is axillary levels 1 to 3, the supraclavicular nodes, as well as the internal mammary lymph nodes. Now, if patients undergo axillary lymph node dissection, we often will omit the dissected axilla and just go after the regional lymph nodes that were not dissected. But in some cases, we might actually go after the dissected axilla too. For example, if they have less than 10 nodes removed, if they have greater than 50% of the nodes positive in the axilla, or if they have kind of fixed or matted lymph nodes. So there are indications to treat the dissected axilla, but typically we just treat the undissected axilla and the other regional lymph nodes. A sentinel lymph node biopsy is not an axillary dissection. So if they just had a sentinel lymph node biopsy and we need to treat the axilla, we'll treat everything. So we talked about radiation as an adjuvant treatment to reduce the risk of the breast cancer coming back locally. So radiation, remember, offers a local control benefit. And now let's talk about systemic therapy. And this is where it gets really complicated because the systemic therapy depends on the molecular subtype of cancer that the patient has. There's a few different types of systemic therapy. So endocrine therapy, all hormone positive patients will receive some form of endocrine therapy, whether they have localized disease or metastatic disease. And usually endocrine therapy is offered in the adjuvant setting. So the great thing about having a hormone positive breast cancer is that we can treat it with endocrine therapy. So any patient with hormone positivity will get endocrine therapy. Now, chemotherapy. Chemotherapy is something that we have discussed in the past, can be used either neoadjuvantly or adjuvantly, depending on the scenario. There's been studies that have compared neoadjuvant to adjuvant chemotherapy, and it doesn't affect the patient's survival. So if the patient's going to be needing chemotherapy, it doesn't really matter if we give it neoadjuvantly or adjuvantly, but that's more of a clinical decision. So as we've talked about, if we are interested in downstaging so that a patient is amenable for breast conserving surgery, we might think about upfront chemotherapy to kind of reduce the intensity of the surgery that they'll get. We'll talk about the different kinds of chemo regimens that we offer for breast cancer. Other therapies to be aware of, so targeted therapies. So the best example of this for breast cancer is the drug called trastuzumab, or the brand name is Herceptin. This is a HER2-directed antibody, and it's given for patients that have HER2-positive breast cancers. We often will add this treatment to chemotherapy regimens in patients that have HER2 positive breast cancer. So if a patient is HER2 positive and they're going to be getting chemotherapy, then we'll add the drug trastuzumab or Herceptin to their therapy. And then finally, immune therapy. So pembrolizumab or Keytruda is the drug that has been studied for triple negative breast cancer patients in a clinical trial called Keynote 522. So pembrolizumab is an anti-PD-1 agent, and it's shown a benefit in triple negative cancer patients. So we often will add immunotherapy to chemotherapy regimens for triple negative patients. So just to give an overview of what types of systemic therapies we think about for breast cancer patients. Let's talk a little bit about the different kinds of endocrine therapy and what their mechanisms are. So most of the time, endocrine therapy is given in the adjuvant setting for 5 to 10 years for patients with hormone-positive breast cancer. The standard duration is usually 5 years, although they might consider 10 years if the patient has additional risk factors. For example, if they developed the cancer while on hormonal prophylaxis. Now, what are some of the agents that we use to treat breast cancer with endocrine therapy? So in premenopausal patients, the drug that you'll hear used most often is tamoxifen. It's usually 20 milligrams of tamoxifen given daily for 5 years. Tamoxifen, the mechanism is it's a selective estrogen receptor modulator. So it selectively acts as an antagonist in the breast, but then it acts as an agonist in the bones in the uterus. The side effects of tamoxifen include hot flashes and increased risk of clots. And the reason we give it typically in premenopausal patients is because that increased risk of uterine cancer is actually more of a concern in postmenopausal patients. So remember, tamoxifen is an SERM and it's typically used in premenopausal patients. Sometimes in premenopausal patients, we might consider adding LHRH agonists like leuprolide or goserelin for ovarian suppression. These are kind of an extra endocrine regulation, and we might just consider adding them to therapy like tamoxifen, but they're never given alone. They're always given as a supplement for ovarian suppression. Besides tamoxifen, the other type of endocrine therapy that's most commonly used in postmenopausal patients is aromatase inhibitors. So examples of these are anastrozole and letrozole. Aromatase is an enzyme that's located typically in our fatty tissues, and it actually converts different precursors like testosterone and androstenedione to estrogen in the fat cells. And so aromatase inhibitors inhibit that enzyme and prevent the conversion in the peripheral tissues. So aromatase inhibitors are typically used in postmenopausal patients. You can't really give anastrozole to premenopausal patients because in premenopausal patients, the ovaries are active. So if you inhibit aromatase, the ovaries will just increase their production of hormone in response. So that is why aromatase inhibitors are used in postmenopausal patients. Side effects of these are increased risk of bone loss, arthralgias, myalgias. There's not as much of a risk of DVTs or uterine cancer with aromatase inhibitors as there is with tamoxifen. So we know that any patients with hormone-positive breast cancer are going to get endocrine therapy. Now the question is, when do we give chemotherapy? And this is something that used to confuse me a lot, not just chemotherapy, but systemic therapy in general. And I think what's important to understand is the systemic therapy that we think about really depends on the molecular subtype that the patient has. So think about it as 3 different types of patients: hormone-positive patients, HER2-positive patients, and then finally triple-negative patients. Okay, so the hormone-positive patients, they're hormone-positive and HER2-negative. These patients are always going to get endocrine therapy, right? Because we have an easy target. We have the hormone-positive receptors. If these patients have early stage disease, so they have node-negative, hormone-positive, HER2-negative disease. Remember in part 1, we talked about the oncotype risk score. You can use different types of genomic testing, whether it's oncotype or mammaprint or whatever it is, to determine whether or not these patients receive chemotherapy. So if they're early stage, we use the genomic risk testing, such as oncotype, to determine if they need chemotherapy. If the patients have locally advanced disease, so either T3 to T4 disease or node-positive patients, these are the patients that typically will be getting chemotherapy. So any clinically node-positive premenopausal patients or any patients that are postmenopausal with 4 or more positive nodes will typically get neoadjuvant chemotherapy. And the chemotherapy regimens that we give depend on if we're treating for node-positive or node-negative disease. So node-positive patients, we typically treat them with dose-dense ACT, which is adriamycin plus cyclophosphamide, and then followed by paclitaxel. So ACT stands for adriamycin, cytoxan, and Taxol. So adriamycin is the drug doxorubicin. Cytoxan is cyclophosphamide, so they get adriamycin and cyclophosphamide, and then they get Taxol, which is paclitaxel, and that's kind of the regimen that we typically give for node-positive patients. The biggest side effect to keep in mind with adriamycin is that it can cause permanent cardiotoxicity, so these patients should be getting echocardiograms up front. For node-negative patients, a regimen that is commonly used is TC, which is the T here stands for taxotere, which is docetaxel, and cytoxan, which is cyclophosphamide. So node-negative, we might consider TC for 4 cycles, Q21 days. So it's given over 12 weeks. With the taxanes, the biggest side effect to keep in mind is total body alopecia that's seen, as well as neuropathy. Okay, so the big takeaway here for hormone-positive patients is that for early stage patients, we determine their need depending on their genomic risk scoring. But if they have very locally advanced disease, so either T3 to T4 or they're node positive, then we think about adding chemo. And chemo can be given neoadjuvantly or adjuvantly, but the approach just depends on the menopausal status and how many nodes are positive. So some regimens that we use are ACT as well as TC. Now for HER2 positive patients, remember we talked about trastuzumab or Herceptin, which is a targeted therapy against the HER2 receptor. So in HER2 positive patients, anything typically larger than 0.5 to 1 centimeters will get chemotherapy. So anything T1B to T1C or above will be getting chemotherapy. For HER2 positive cancers, in the neoadjuvant setting, we typically give TCHP, which is docetaxel, carboplatin. So now the C is different too. It's carboplatin, Herceptin, and Perjeta. And Perjeta is just pertuzumab, which is another targeted agent against the HER2 receptor. HER2 is also cardiotoxic, just like adriamycin, but unlike adriamycin, HER2 actually causes a temporary cardiotoxicity. Adriamycin causes permanent cardiotoxicity. So HER2 positive patients will get TCHP typically up front. And then if they have a pathologic complete response, we typically just continue the trastuzumab for a year, every 3 weeks. If they have an incomplete response, then the adjuvant therapy that we offer these patients is something called TDM1, which is the brand name for this is Kadcycla, and it stands for trastuzumab emtansine. So it's actually trastuzumab that's conjugated to a special cytotoxic agent, and that drug is called TDM1. So HER2 positive patients, the systemic therapy they typically get is TCHP, continue the trastuzumab if they have a PCR to that, and then TDM1 if they do not have a complete response. And then finally, we get to our triple negative patients. And just like HER2 positive, typically anything greater than 0.5 to 1 centimeters, if it's triple negative, will be getting some type of chemotherapy. Before the trial Keynote 522 came out, we used to just give these patients neoadjuvant dose-dense ACT. Remember, dose-dense is the same dose, but it's just given every 2 weeks instead of every 3 weeks. And these patients will often need growth factor to account for cell count recovery. But so it used to be we would just give them dose-dense ACT, but because of Keynote 522, we now give them neoadjuvant TCAC plus Pembro. So what is TCAC? It's paclitaxel carboplatin for 4 cycles every 21 days over 12 weeks, and then doxorubicin and cyclophosphamide with pembrolizumab given for 4 cycles every 21 days over 12 weeks. The trial Keynote 522 included patients that had node-positive patients or anyone with a tumor over 2 centimeters. And so these are the patients that will be getting TCAC plus Pembro. If patients have an incomplete response to neoadjuvant therapy and they're triple negative, then there's another trial that we'll talk about in the future, but these patients will typically get adjuvant capecitabine, which is brand name Xeloda. So a lot of information to unpack here regarding common chemotherapy regimens. Remember that the chemotherapy kind of depends on whether they're hormone positive, HER2 positive, or if they're triple negative. The special targeted agents that we add for HER2 positive patients are the trastuzumab Perjeta for HER2 and TDM1 in the adjuvant setting if they don't have a complete response. And for triple negative patients, we're starting to add immunotherapy with pembrolizumab or Keytruda, which is a PD-L1 inhibitor. Now, when we give neoadjuvant chemotherapy, we give it with the hope that the patients will undergo some type of downstaging, right? So that they'll have a response to the upfront chemotherapy and the cancer stage will improve as a result. The best response to neoadjuvant chemotherapy is actually seen in triple negative patients, around a 65 to 70% pathologic complete response rate following neoadjuvant chemoimmunotherapy for triple negative patients. HER2 positive patients also have a pretty good response, maybe not as good as triple negative, but still around a 60% PCR rate. It's really the hormone positive HER2 negative patients that have the worst rate of PCR following neoadjuvant therapy, only 10 to 20%. That's something that's important to keep in mind when you're talking to patients, because we know that if they have hormone positive HER2 negative disease, the chance that they actually have a complete response is pretty low. So this was just a ton of information, and breast cancer is a very complex, kind of action-packed disease, and there's a lot of data and evidence base for why we do what we do. In future lectures within this breast cancer series, we will try to dissect some of that evidence and kind of understand the data behind why we do what we do. In the meantime, I'd like to conclude this talk by just going through a very quick summary of everything that we talked about. So when we manage breast cancer, everybody gets surgery as long as they don't have metastatic disease. And the goal is to get negative margins. If they don't have negative margins, we ask the surgeon if they can take them back to the OR to get negative margins. There's different types of surgeries. There's lumpectomy or segmental mastectomy, and then there's total mastectomy. And most patients, in addition to surgery, will get sentinel lymph node biopsy. Axillary lymph node dissection is much less common in the modern era. Chemotherapy, it doesn't matter if we give it neoadjuvantly or adjuvantly, but sometimes we prefer to do it up front so that we can kind of downstage the patient and have them require less invasive of a surgery. If patients have an incomplete response to neoadjuvant chemotherapy, then we start to consider adjuvant regimens. And there's different regimens depending on what their molecular subtype is. So if they're HER2 negative, we usually do Xeloda. If they're HER2 positive, then we typically do TDM1. Indications for giving chemotherapy. For hormone positive HER2 negative patients, it's really dependent on that oncotype score. So if it's 26 or higher for postmenopausal, or if it's 18 or higher for premenopausal patients. If they have 4 or more positive nodes and they're postmenopausal, or if they have any positive nodes and they're premenopausal. And typically, if they have T3 to T4 disease or N positive disease, they will receive neoadjuvant chemo. For HER2 positive and triple negative for chemotherapy, it's typically more of a size cutoff. In terms of hormone therapy, any patients that receive adjuvant or any patients that are hormone positive will receive adjuvant endocrine therapy for at least 5 years. And remember, we said that tamoxifen is typically given for premenopausal patients and anastrozole is typically given for postmenopausal patients. The hormone therapy can be given concurrently with radiation, or it can be started after radiation is complete. And typically, this is just institution dependent. In terms of radiation, all patients will get adjuvant radiation after a lumpectomy because lumpectomy plus radiation has been shown to be equivalent to a mastectomy. Although there are a subset of patients, typically early stage favorable risk, so small tumors, hormone positive, and elderly patients in which we might consider omitting radiation, counseling them that they still have a higher risk of local recurrence that radiation can help to decrease, but sometimes that risk of local recurrence is so low that patients are okay with that. So it's really a risk-benefit discussion in these early stage favorable risk elderly patients. After a mastectomy, the indications for post-mastectomy radiation, I typically think about it as stage 3 disease. So if they have T3 to T4 disease, if they have greater than 4 positive nodes, or if they have positive margins. If they're T1 to T2 and have 1 to 3 positive nodes, it's an area where we strongly consider. T3 node negative is controversial, but we try to account for higher risk features, whether it's LVSI, their grade, closer positive margins, if they're premenopausal. And then finally, when do we irradiate the regional lymph nodes? Typically, it's for patients with node-positive disease. And regional lymph node irradiation includes axillary levels 1 to 3, the supraclavicular lymph nodes, and the internal mammary lymph nodes. We consider regional lymph node irradiation in any patients that have any microscopic disease or higher. So ITCs we typically disregard, but if they have microscopic disease, so 0.2 millimeters or higher, and then we consider other high-risk features like young age, grade, hormone status, LVSI, Ki-67. In some cases, we might consider using what are called high tangents. So that basically just means radiation to the lower axilla. But otherwise, we typically will offer comprehensive regional nodal irradiation. So huge deep breath now because we finally made it through this talk. I was hoping it would be shorter than part 1, but here we are, almost an hour, and it's way longer than part 1. But hopefully this was helpful because we did talk a lot about the staging and kind of really got into the nitty-gritty details that you will have to memorize for boards. And then we kind of gave a bird's eye view, believe it or not, in this 1 hour of the treatment for breast cancer. So hopefully you have a better grasp of what kinds of considerations we're thinking about for surgery, adjuvant radiation, and systemic therapy as well. It's impossible to cover every single detail about breast cancer. Here, I really just wanted to give an overview so that you feel somewhat educated about breast cancer. And in future lectures in this series, we will start talking more about the evidence base for breast cancer and explain why we do what we do. Thank you so much for all of your attention thus far. I hope that this was helpful to you.